A very good morning to one and all. Today we're going to talk about one of the most commonly done procedure in oral surgery, that is exodontia, its principle, technique and complication. Now extraction of a tooth is considered to be one of the most formidable procedure by a patient. Now this is because of the previous experience of the patient during the extraction procedure that even today the extraction phobia is very difficult to manage in a dental clinic. Now today in this lecture we will see the various techniques that can be used to decrease this phobia of the patient and make these procedures more comfortable to the patient. To begin with, the definition of exodontia. By Jeffrey and Ho, it is defined as a painless removal of a whole tooth or a root with minimal trauma to the investing tissue so that the wound healed uneventfully and post-operative prosthetic problems are less. You might be wondering, is there any indication? Why do we need to extract the teeth? Yes, we need to extract the teeth when they are grossly carious, when you cannot do a root canal treatment and you have to remove them. You need to extract root pieces which cannot be restored. You need to extract those teeth which are available with perioapical pathologies like cyst or tumor. Non-vital teeth with unfavorable fractures need to be extracted because they are very difficult to restore. Teeth that are periodontically compromised, like molars that have furcation involvement, in that case you have to extract them. Deciduous retained teeth, impacted teeth, tooth that are present in the line of fracture. For the healing of fracture, you need to remove these tooth because these tooth can act as a nidus of infection. So proper healing and bone formation, you need to extract the teeth along the line of fracture. Teeth need to be extracted for orthodontic treatment so that you provide space for tooth mobility. In providing space, you could align the teeth properly in case of prosthetic rehabilitation and before radiation therapy. Is there any contraindication? Yes, it is. It could either be local contraindication or systemic contraindication. Local contraindication, like those teeth which can be saved by root canal treatment, they should be retained. In case of acute necrotizing gingivitis, you need to restore the gingivitis first, then address the extraction of the tooth. In case of acute infection, control the infection, then move on to the extraction. If you extract a tooth in presence of infection, there is post-operative infection and instead of healing, you will have a dry socket. In case of irradiated bone, you need not extract a tooth because the vascularity and hypocellularity is present in irradiated bone. If you do the extraction, there is chances of osteoradionecrosis. Let's move on to the systemic contraindication. It could either be absolute or relative. In absolute systemic contraindication are uncontrolled diabetes mellitus. In diabetes, the glucose level is already increased, and when you're doing an extraction, the extraction procedure causes stress formation. Now this stress formation have a number of neurohormonal changes that is taking place. There is secretion of hormones like glucagon and cortisol, which causes increase in hyperglycemia. Okay, so now these hormones causes increase in hyperglycemia. Along with that, you have uncontrolled diabetes. All this coupled together will increase the sugar level in your blood, which forms a very conducive environment for the microorganism to grow and result in infection. And there are high chances of dry socket formation. Next is in case of renal failure and liver cirrhosis. We all know that local anesthetic used before the extraction are excreted through kidney and liver. In these cases, if there is impairment in the kidney and liver, the extraction procedure is hampered. So even a small dose can cause toxicity. In case of cardiac failure, to avoid cardiac toxicity, extractions are avoided. Relative contraindications like controlled diabetes, controlled hypertension, and in pregnancy. Yes, you should avoid extraction during pregnancy. That is, if it is done in the first trimester, it could cause abortion. And if it is done in the last trimester, it could cause premature labor and delivery. But if in case you have to do an extraction, if it becomes very important, then with the consent of a gynecologist, you can offer extraction in the middle trimester. That is the second trimester. That too, taking all precautions in hand. After the extraction, the post-operative medication should also be given properly. That is, mild antibiotics like simple amoxicillin can be given and mild analgesic like crocin. Avoid non-steroidal anti-inflammatory drugs. The next is those patients who are on steroid therapy. Okay, because of steroids therapy, the adrenocorticotropic hormone secretion is less. And in stress, to combat the mechanism of stress, you need this adrenocorticotropic hormone. So if you do the extraction in those patients who are on steroid therapy, this could result in adrenal crisis. So what you should do in these cases, consult a physician, start the patient on steroid therapy at least 2 to 3 days before the surgery or extraction, then followed the therapy and taper it slowly. In case of anticoagulant therapy, you need to do a proper physical consent and then opt for the extraction only after you get a proper clotting profile of the patient. Now let's move on to the principle of extraction. 3 things you need to keep in mind, that is clear access and vision of the surgical field along with use of controlled force and uninhibited path of removal. Now before we move on to the mechanical principle, let's take a look on the patient as well as surgeon's position during extraction. To begin with the patient position. The patient should be in a relaxed position as possible. The chair should be reclined to 45 degrees. When you're doing an extraction in the maxillary quadrant, you see to that when the mouth is open, the occlusal of the maxillary teeth make an angle of 45 to 60 degrees to the floor. Then if you're doing extraction in the mandible, you see to that the occlusal surface of the mandible is parallel or make a 10-degree angle to the floor. At the same time, the height of the chair should be such that in case of maxilla, it should be above the elbow level, and in case of the mandible, it should be below the elbow level. Now let's talk about the surgeon's position when the surgeon is doing the extraction. The surgeon, in case of maxilla, the surgeon will stand on the right side of the patient, in front of the patient. Okay, and the maxilla, the chair is above the elbow level. In one hand, you will hold the extraction forceps, and with your other, that is the left hand, you will use 2 fingers, that is your index finger and your thumb, to hold the alveolus in such a way that your index finger is in the buccal vestibule and your thumb is in the palate to support the alveolus, and then you will remove the tooth. In case of the mandible, 3rd quadrant, okay, you will stand in front of the patient and on the right side. In such a way, your index finger and middle finger, they support the alveolus. As you can see here, this is your mandible and this is your 3rd quadrant. When you're standing in front of the patient, you hold your index finger in the buccal vestibule and your middle finger in the palatal vestibule, and your thumb is at the inferior border of the mandible. This is the way you support the mandible, and then you do the extraction with your right hand. In the extraction of the mandible, the surgeon should be standing very close to the patient and in front of the patient. When you're extracting the mandible in the 4th quadrant, okay, you will stand behind the patient in such a way that your index finger and your thumb is lying on the vestibule holding the alveolus and you are extracting it. Now let's move on to the mechanical principle extraction. It consists of 3 things: lever principle, wedge principle and wheel and axial principle. Take a look at the lever principle. In the lever principle, we have 3 basic things. We have the fulcrum, the effort arm and the load arm. The fulcrum is usually present between the effort and load arm in such a way that the effort arm is longer than the load arm. Now the longer the effort arm, the better is the mechanical advantage. Now this principle is used in case of when you're using an elevator to extract a teeth. So when you're using an elevator, you will engage the tip of the elevator to the tooth, use the bone as a fulcrum and remove the tooth. The next is the wedge principle. The wedge principle has 2 movable inclined planes, the blade and the base. The base acts as an effort and the blade is where the result is seen. Now in this case, for an example, you put the elevator into the socket in such a way that the tip is between the tooth and the bone. You try to engage it. In such a way, you separate the periodontal ligament and remove the tooth. The next principle is wheel and axial principle. It is nothing but a modified form of lever. Here, the effort is around the circumference of a wheel, which turns the axial and lifts the weight. The greater the diameter of the wheel, the more is the mechanical advantage. Now, this principle is best used in crossbar elevators. wherein the tip of the crossbar elevators are engaged into the tooth and the handle are rotated in a circular motion which act as an axial to elevate the tooth. Now let's take a look at what the instruments are required for the extraction. To begin with, the elevators. Now, indication of elevator is that they're basically used to luxate a tooth. They're used to remove root pieces. They're used to remove those teeth which cannot be used in case of a forcep, wherein the access is less, so you need to use an elevator to remove a tooth. In case of grossly carious tooth, you need to use an elevator, because if you use a forcep, you'll keep on crushing the crown and root. So in that case, you need to use an elevator. Okay, now an elevator, it has a handle, it has a shank and a tip. Okay, these are the three parts of elevator. Now elevator, depending upon their shape, they are of three types. You have straight elevators like these, then you have angulated elevators like these, and the third one is the crossbar elevator. Okay, the most commonly used elevator are three. One is the periostal elevators. As you can see this is basically used to reflect a mucoperiostal flap. You have a blunt end which has a concavity. This is used to reflect the flap. You also have a sharp end which is used to separate the interdental papilla. The next elevator is the apexo elevator. Now apexo elevator can be of three types. That is, one is the straight apexo elevator. Now this straight apexo elevator has a handle, has a shank and a blade. Now this is used to remove root piece from the maxillary premolar canine region. This concave surface, it might be smooth or have serration. This is used along the mesial surface. So how do you hold an elevator? You have a firm grip, you index finger on the shank, and then this curved surface is along the mesial aspect of the root. So if you need to remove this premolar, here is the premolar, here is the concave surface, and you will engage here. Always see to that you have a fulcrum as bone, not an adjacent tooth, so that you luxate the tooth that is to be removed, not the adjacent tooth. This is the movement that is done to remove a tooth. The other apexo elevator is number 4 and 5. The blades are at right angle to the handle. They are basically used to remove the mandibular root pieces. It has a concavity here which engages onto the mesial aspect. So since it's engaged into the mesial aspect, it is used in case of the third quadrant, that is on the left side of the patient. These are always paired. So if your concavity is this is towards the left side, and if your concavity is facing towards me, that is, it is used for the right side of the patient. Let's move on to the crossbar elevators. Crossbar elevator at a handle which is right angle to the shank and a working tip. Now crossbar elevators are also of three types. The 11 number, the 14 number and number 1, depending upon the shape of the tip. The 11 number is this. It has a very sharp pointed tip. It is basically used to remove the molar tooth, wherein the buccal cortical plate is very thick. So you hold the elevator like this, put your index finger here. This is the concavity. You will engage this onto the buccal aspect. So if this is the right side, that is the fourth quadrant, you will engage into the furcation area. As you can see here, engage it into the furcation area. The concavity is here and you try to rotate it. Now this, as I mentioned earlier, work on wheel and axial principle. Now this act as your wheel, shank as at your axial, and here is the force applied to deliver the tooth. Let's move on to the forceps that I use. Now the forcep has a handle, it has a hinge and a beak. Now beaks have serration. Now these serration are to grasp the tooth firmly. For each maxilla you have another forcep, and for mandible you have a different forcep. In case of the mandible, the beak is at right angle to the handle. As you can see, the two difference between the maxilla and the mandibular forcep. Now, in case of the maxillary anterior tooth or cuspids, this beak is curved in nature and it is close towards each other. In case of premolars, the beaks are apart. And in case of molars, you will have One beak is smooth and the other beak has a serration, that is a triangle. Now this triangle will help to engage into the furcation area. So how will you hold and remove the tooth? Your grip will be something like this. If you're removing a maxillary tooth, now this will come on the buccal aspect. The triangle will come on the buccal aspect and the curved area is going to be on the palatal aspect. So you will hold the tooth like this. And then you will do buccal, lingual movement, rotate it and remove it. Now how do you remove a tooth with the help of a forcep? First of all, you hold the forcep at the handle as far as possible, grasp the tooth and push it apically. When you're pushing it apically, you're first trying to separate the mucoperiosteum from the teeth. Then you compress the buccal and the palatal cortical plate. After compressing, you release the pressure and try to put the beak inside. Now this mechanism of compression and releasing caused the periodontal ligament to break in the cervical region, and this helped to engage the beak of the forcep between the bone and the tooth. Okay, once you are holding the tooth, see to that the forcep is resting on the root below the cemento-enamel junction. If you hold it at the crown, there are chances that you might do a crown fracture. So you hold the tooth at the root region, apical to the cemento-enamel junction. Once you have a firm grip, then try to luxate the tooth in buccal and lingual direction. When you move the tooth in the buccal direction, the root tip is deviated to the palatal or lingual direction. When you move it towards the palatal direction, the root tip is deviated to the buccal region. So there is torquing movement that takes place. Now this torquing movement helps to break down the periodontal ligament and cause the tooth to pop out. Now what happened? In the maxillary region, the buccal and cortical plate, the palatal bone is comparatively thicker. So you have to give more buccal pressure and remove the tooth buccally. Similarly, in the mandibular region, when you're removing the tooth, you need to apply more pressure in the mandible buccal region and then remove the tooth. Whereas in case of posterior region, the buccal cortical plate is thicker. So you do a strong palatal pressure and then try to remove the tooth buccally. Now what precaution that you need to take when you're using a forcep? First of all, you need to engage the forcep properly. Select the proper forcep for a proper tooth. Hold it properly. Hold it far away from the handle to take the mechanical advantage of the lever principle. After you hold, have a firm grip. You make sure that the forcep is aligned parallel to the long axis of the tooth and a controlled force is applied to remove the tooth. Now extraction can be done in case of an open method or a closed method. Closed method is the thing that we use with elevator and forcep. Open method are indicated in case of dilacerated root and hypercementosis, wherein there are chances of apical third of root fracture. So if this fracture occur, you need to raise a mucoperiosteal flap, do a slight amount of bone guttering, then remove the root piece. In case of difficult root pieces, which are not seen clinically, that is below the cervical margin, you need to raise a flap, do the bone guttering and then remove. In case of root canal treated teeth, you might have to do an open method. In case of impacted tooth, you definitely have to do an open method. Now what are the complications of extraction? It could be the complication can arise during the procedure, that is laceration of soft tissue. So how you could avoid it? By guarding the soft tissue when you're doing the extraction. Guarding the soft tissue with your index finger and thumb. Using controlled force of the elevator and forceps so that it doesn't injure the adjacent soft tissue. Then the next complication is luxation of the adjacent tooth. When you're using the adjacent tooth as a fulcrum in case of elevator, there are high chances that you might luxate the adjacent tooth rather than the tooth that has to be extracted. So use bone as a fulcrum, never an adjacent tooth. Crown fracture. When you're using a forcep, sometimes you tend to hold just the crown, not the tooth. In that case, you could result in a crown fracture. If crown fracture occurs, you need to drill the bone and then remove the root. So to avoid crown fracture, it is important to hold the root of the teeth, and in case of molars, you have to hold the furcation area to remove the tooth. The other complication that can occur is root tip fracture. Now root tip fracture can be removed by surgical method. Intraoperative bleeding can also occur, which can be controlled by application of pressure pack. Let's move on to the post-operative complication which occur, that is swelling and trismus. Swelling and trismus is body mechanism towards surgery. Your body is trying to cope from the surgery. There is inflammation, collection of exudate in that area resulting in swelling followed by trismus. Now this can be avoided by asking the patient to have cold fermentation immediately after the surgery, that is on the day of surgery. Then from the next day you can start with hot fermentation. Now this hot and cold fermentation help to mobilize the tissue fluid that is collected in the area and decrease the swelling. The next post-operative complication could be retained root piece. Sometime in apical, 1/3 of the root piece might remain inside. If this root piece is very close to the anatomical structures like inferior alveolar canal, maxillary sinus, it is better to let it be there, because what happens as the time passes by, these root tips will come more towards the cervical area and later on you could do the surgery and remove it. But if these root tips are away from the surgical important structures like the inferior alveolar canal or maxillary sinus, at that time you could explore the cavity again and remove it. Post-operative bleeding can take place. If there is an incidence of post-operative bleeding, try the patient to, this could be because the patient is continuously spitting out after the surgery. Clot dislodgement can take place. So ask the patient to bite on a cotton bag for 1 hour. Okay. Still if bleed, explore the area, put Abgel inside or any other hemostatic agent like gel foam, Abgel, Surgicel. And if you could approximate the mucosa, suture it. Okay. After this, if still there is bleeding, do a blood investigation and see for the bleeding profile of the patient. Normally bleeding should stop. If the bleeding continues, then it could be because of underlying medical problem which was not detected before the surgery. If this thing happened, you need to see to a physician and accordingly do the coagulation profile and treat it. One of the dreaded complication that is seen after extraction is dry socket. Now dry socket is characterized by severe localized pain 4 to 5 days after the surgery. This is accompanied by disintegration of interalveolar clot along with very foul smelling odor. You will see a necrotic bone tissue and inflamed margin which is not at all healing. Now this is because of two main theories. One is because of fibrinolytic theory and bacterial theory. As per Burns fibrinolytic theory, it states that during extraction after it, the inflammatory process can sometimes retard healing. What happened during inflammation? It releases cytokines which causes disintegration of fibrinogen into fibrin, eventually causes clot disintegration and result in formation of dry socket. As per the bacterial theory, if there is a pre-existing local infection or a periodontal infection, because of which there is already microorganism available at the site of extraction, and rather than treating the acute condition, you do the extraction. So there are chances of infection and result in formation of dry socket. So once dry socket occur, what you can do is call the patient, inspect the area, freshen up the margins, remove all the necrotic bone, curettage the area, induce fresh bleeding. If the margin can be approximated, suture it. If you are not able to approximate the margin, then you have to place a dressing. Now the dressing can be in form of an impregnated gauze with zinc oxide or chlorhexidine. You pack it, call the patient every alternate day, see how the healing is taking place. Once you see a fresh granulation tissue is being formed, stop. No need to put a dressing again. Ask the patient to use chlorhexidine mouthwash and give an antibiotic coverage of metronidazole, because most commonly dry socket is mainly because of anaerobic organism. So you need to give metronidazole along with amoxicillin and painkillers to decrease the post-operative pain. With this, I conclude my lecture by saying that extraction is not an emergency. It is an elective procedure, which by proper diagnosis, treatment planning and use of judicious technique, we can minimize and decrease patient phobia and make these procedures more comfortable to the patient. Thus, keeping this in mind, we can change smile one at a time. Thank you.